I'm Dr. Daniel Gams Massi from the Moving Along Journal of the International Parkinson and Movement Disorder Society. And I'm joined today by Dr. Indu Subramanian, who is a co-author of this important manuscript on equity in care for patients with Parkinson disease, especially patients from Africa. This paper focuses especially on the availability of levodopa in sub-Saharan Africa, uh, which is still a challenge because it remains severely limited, creating a preventable treatment gap in care for people living with Parkinson's disease and increased burden of the disease in this region. Uh, I've went through the paper and I was impressed about not only the quality of the paper, but the reality highlighted by this paper. So, could you tell us why have you chosen to write this paper?
Yeah, I think it's a bit unexpected. Thank you so much, Daniel, for taking the time to interview me. And I'm humbled to be talking to someone who's on the ground there in Africa, who is dealing with this every day. So I am a neurologist in Los Angeles. I work at UCLA, and though I work at a VA, which is taking care of veterans, which has poses its own problems, I've just been so just amazed by the work that you have to do in Africa, taking care of a huge number of Parkinson's patients, many young patients with Parkinson's, dealing with stigma on the ground that is huge, and not even having the basic medication of levodopa available. We have a wellness task force that we started talking about exercise, diet, sleep, things like that. And as we were writing that paper, it just struck me that we in North America and other resourced countries have this to add to pharmaceuticals and surgeries, but in many parts of the world, this is the only strategy that you have to offer your patients. And so I wrote this paper. I did a number of interviews during the pandemic and met my co-authors, Dr. Professor Okubadejo and Dr. Tash Misbah, and was struck by their thoughts on this. And we decided to work together to write a paper that John Stossel was kind enough to feature in Movement Disorders. And we've gotten a very good response, including folks like you who are on the ground and other countries as well, Pakistan, many parts of the world, India. I think we're not alone, in talking about this, just about Africa. But it just struck me that it's the, I think, 70th anniversary almost of this very basic drug, levodopa, and yet there are so many barriers to getting this medication for your patients over there. So we thought we would sort of highlight this in this paper.
Thank you very much. And could you please resume in few words the main point of the manuscript to our audience?
Yeah. I mean, so we come up with here a sort of a call to action in some ways of things that we can do both on the ground in sort of the universe of policy level, and then somewhere in the middle with what pharmaceutical companies and other folks can do. One of the problems in Africa is that I guess every country has its own issues. Every country requires registering the medication. Every pharmacy can get it, not get it. The supplies are very different. There's not one generic that makes a company that makes this drug. Many of the generic companies are outside the country and have to import the drug. And those companies may not find the medication to be a lucrative thing to bring into the country given the barriers. And so I think there's barriers of that sort. We have a huge workforce issue in Africa, and we have a huge workforce issue across the world with very few neurologists and very few movement disorder specialists. And I think you guys have exploding numbers of cases. I heard that you have a lot of young onset patients, and so these basic medications are very important to restore quality of life in this sort of disorder. I also know that even when you can get it for your patients, my understanding is that it's so expensive for your average family there or your average person that they may have to give up, feeding their family or sending their child to school just to get, a supply. I also was made to understand that, the pharmaceutical companies sometimes can bring it in, and then the supply at the pharmacy level can be very erratic, where sometimes the family can get it from the pharmacy. They might come to the same pharmacy and they'll be told that there's no supply at all the next month. And so it's, very, very intermittent, which sets up, sort of a strategy where a drug that should be administered very consistently to patients, the patient is then withdrawing, I guess, from the medicine when they can't get a supply. And I also understand that there's anticholinergics and other drugs that cause more side effects being delivered to some of these patients, which then puts people at an increased risk of, cognitive side effects and other things. And they're living in a very hot climate, taking medications that alter sweat mechanisms and things like that. And so, the ideal thing is for us to work together to really bring, our minds and our hopefully group energy to help, solve this problem, along with you, to get hopefully drug in every mouth of every patient living with Parkinson's around the world, which is what I've been sort of struck that I feel the need to help with that.
Given the shortage of neurologists and often the lack of education resources or access to available resources, how do you feel we could train non-neurologists and even non-physician health worker on the diagnosis and treatment of patients with Parkinson disease? What will be the first crucial steps?
Well, maybe you can help me answer this question as well, but I'll take a crack at it. So I think, we don't have neurologists, is my understanding, in some parts of Africa completely. But I think, we have some physical therapists, some nurses that could be trained. I know some of those are also very stretched thin with many other diseases that they have to also care about in the neurology space. My understanding that there are health promoters that are in the community, so community health promoters that can be trained on the ground locally. I understand that from Dr. Misbah that there's a program called MH Gap or Mental Health Gap that is in some countries where this type of health promoter, primary care health promoter, can be educated on various diseases affecting the brain, including, I think there's a program on dementia. There's not a program right now on Parkinson's, I understand. And so perhaps, working with this type of population, educating them through programs. Dr. Misbah is doing one on theater, creating some theatrical play, teaching promoters around a love story, maybe with a Parkinson's patient, and highlighting the disease in a positive way, and so helping to dispel stigma even in these populations, and getting education to the grassroots workforce. So I think, we have to get away from just training the trainers, and the very high level neurologists. I think we have to get really into who's on the ground that we can educate. I think also education of the masses through public service announcements, religious leaders and other people that may be touching these patients, teachers in schools, things like that, sort of community-based resources where we can to help increase the sort of knowledge base of what does Parkinson's look like, that young people can get it, women can get it, African folks can get it, and really sort of teach that. But maybe, do you have any other thoughts, Daniel?
Yeah, yeah, I think you are perfectly true. The target will be the community. So by using a community health provider, we will have two advantage. The first advantage is that the patient could be diagnosed early, and the second advantage is that they usually know very well the patient, the family, the context, so that the management can take into account the holistic environment of the patient, not only the prescription of the medicine.
Absolutely. That sounds awesome.
So, what about we are talking about the community, and we know that there is a lot of stigma surrounding Parkinson disease in Africa. So, stigma and awareness are major barrier. What community level intervention will you prioritize first, and what success metrics will you track to to prove the impact of interventions?
I mean, I think, the metrics and things like that, the studying of this is another whole, complicated task. I'm knowledgeable about stigma just in general, in the sense that, there's the society has a stigma on the patient, but the patient then has a self-stigma where they feel that the society has something against them. And so I think we have to tackle this in two ways. So one is, helping to raise awareness of in society that this is not communicable. This is not an infection. This is not something that you're going to catch from the person by being near them. That social connection is actually helpful to the patient. Your loved one will thrive if you take care of them. You bring them out into the community, you keep them engaged. So I think a lot of the times people are hidden because there's a sense that people can catch it. It's something that was witchcraft, a curse. We can say that this is not the case. This is not witchcraft, not this is something that is, protein that's affecting the brain, just like dementia, just like so many other problems. And so I think we want to take the blame from the patient or something that they did and put it on, something that they didn't have control over so that they understand it's not them to blame, that they need to do certain lifestyle things like getting in the community is part of that social connection, exercise, staying engaged, with their community, going to church or going to, their child's, soccer games or whatever it is that they love to do, going to dances, drum circles, whatever, they're continuing to be engaged in their community. These are all part of the medicine, and that the society also has a piece in helping the patient to come out and stay engaged. I think these are things that the message is that we have to convey to put sort of that back in the society, the community that they live, the family that they live, that they need to engage the patient, that the patient is not to blame. I think also having the patient connect with others that look like them so that they can feel not alone through peer-to-peer connection, support groups, things like that, I think will also help them to see that they are not alone. And then again, that public service announcement of just, this is a very common disease. It's very common in Africa, and that there's a lot of patients out there that are not diagnosed yet, and that, this is very treatable, and that we want to have people come forward. So I think these are the messages that I would try to impart.
Thank you. When you talk about the support group, we know how support group are very helpful, not only for the patient to know that he's not alone and to share experience, but also to change policy. And regarding policy, if you had to pick one policy that an African Health Ministry could pull in the next 12 months to expand developer access, what will it be?
I mean, apparently levodopa, I mean, so Parkinson's isn't even part of any dialogue there. This is not a disease that people identify like malaria, like HIV. We have to get in the minds of these policymakers to even make it an official disease in some countries that's even written about. I think that helping to engage pharmaceutical companies, first of all, registering the drug in so many countries is a huge barrier, and I think that prevents, being able to prescribe the drug. So in Cameroon, you told me that you at least have the drug registered, but that's not the case for many, many countries. Each country has to do their own registration, even if it's the same generic manufacturer that's coming in. And so that seems like, a daunting barrier in such a big continent like Africa. So maybe streamlining the process and also helping to make it not a barrier to have to renew it every year. Because my understanding is that, even if you get it, you have to keep doing the paperwork. And a year goes by very fast. And so I think, these sorts of, basic working with pharmaceutical company, a generic manufacturer, maybe to help streamline throughout the continent, to make this paperwork hopefully easier, and renewable, to make sort of a steady flow of this drug there would be my sense. But do you have any other thoughts, Daniel?
Yeah, you are perfectly right. I think the policy will should be adapted regarding each countries and the need of um, patient in each countries. But the first step will be provide agreement so that pharmaceutical company can import the drug into each country. So regarding the policy in your paper, you talk about one interesting thing, the Intersectoral Global Action Plan on Epilepsy, IGAP, approved by the World Health Organization in 2023. So could you explain a little more about IGAP and why it's so important?
So my understanding is in 2023, the WHO had approached, every country in Africa to offer to have them sign up for this. And around Parkinson's disease was specifically named, for I think the first time in this type of measure. And each country in Africa did sign up. So we have, a sign up of each country to say that they will care and will focus and work together to improve things for the patients living with Parkinson's in their country. And my understanding is that they have metrics to which will be measured every year, and then reports given to them. And there's some need to comply with this. So I think they will be held accountable. It's pretty recently after that IGAP measure was signed, and we'll have to see how it pans out. I know many countries rely on North American, like US funding for certain things, and an infrastructure, and even the WHO may be different given the lack of funding that's coming in currently. But my hope is that this at least will help motivate countries to be, accountable for this type of disease state. And I think that's exciting. And so I think that the time is right for us as the Movement Disorder Society to also try to help where we can. What do you think, Daniel?
Yeah, I think so. I think this the IGAP is one important tool, especially to convince health authorities and to show them how important is the management of neurological condition, especially chronic neurological condition such as degenerative disease. So this tool should be, I think, diffused to all neurological community and all health worker working with managing neurological patient to help them try to convince, advocate for better care of patient with neurological conditions. So as you mentioned in your paper, most of the change should be done locally. But how can the International Parkinson and Movement Disorder Society and the movement disorder community can help and advocate to improve this availability of levodopa?
I think we have to make this a priority for all of us at the MDS. I feel like even at the international, the meeting every year, we should be highlighting the issues and where we are, where we come, what are the goals, in a plenary session in the beginning of the meeting, as if it's a very focus, for all of us. And, I, for one, even though I live in North America, I think that we're not serving Parkinson's patients until every patient with Parkinson's living on the planet is served. I think we need to have that mentality that we're all together, and we do that well. I think Professor Fong, who is our president of the Movement Disorder Society, put together a task force on equality and is trying to work with countries, taking best practices from some countries that have had success and teaching it to other countries. We're trying to perhaps put letters together to support certain action plans in some countries from the Movement Disorder Society. This is a pretty new task force, and we'll see kind of where we get, but I'm pleased to be on it, along with my co-authors are both on it as well. And, I think that so again, having a place for this in the annual conference, having more publications that we're highlighting this around, and then, training the trainers, supporting folks on the ground like you, with anything that we can to the LEAP program for younger, perhaps professionals that are taking care of these patients, coming there and training physical therapists and nurses about Parkinson's, and then helping, I think, with any resources that we can to get even into the communities to train these health promoters, making videos, perhaps, different sorts of things to really provide as much help as we can for, people in Africa to get the care that they need.
Patients association are a huge part of making legislation change and to advocate to changes in healthcare. Do you feel the stigma associated with the disease might make difficult the creation of this organization for people living with Parkinson's disease?
Um, I mean, I think that my understanding is that people living with Parkinson's, once they meet each other and they're in the group, they really enjoy seeing others, and they love that sort of group interaction and support. I think identifying patients and getting them to these sort of support groups is part of the problem. I had interviewed a gentleman who on this Moving Along magazine, e-magazine, about the same issue. His name is Kabugo Hannington from Uganda, and he mentioned that he would take small paper and write it on the community buses that would be taking people around, and would have his phone number and write the few symptoms, tremor, things like that, on this thing that a patient could or family member or somebody who knew somebody who looked like that could tear the paper and call him and connect patients that way. Very grassroots, sort of, low budget way. And he would collect the names on his phone and then bring people together. And so I don't think it requires a huge budget or advertising necessarily. All of those would be helpful, but getting in the community in smart ways, talking to people living there, or other providers, and understanding what makes sense for their community, and then helping to provide that, I think, would be key. Additionally, just basic resources. My understanding is, electricity, a clean space, a cooled space, maybe, a ventilated space, a safe space for people to come. Those are things that aren't always available. And so helping to provide that kind of thing. But I think, this is key, getting people together, teaching that, people do okay, that they can see each other and not feel alone. I think this is a huge part of the medicine, in my opinion. And I think, support groups should be, still a huge focus of what the work that's being done there. And I think, I've seen places where a nurse might run a support group and be able to show videos from, the Movement Disorder Society, an exercise video, and the whole group is able to do the exercise together or sing together. And I think that's the type of thing that, can really be an agent of change, is when people see, even not just them in Africa, but all over the world, they see similar faces. So, but what do you think, Daniel?
Yeah, you highlight something which is very important. With little means, can we are able to do more. So this is a good transition to our last question. We know that since the end of last year or the beginning of this year, there were a shutdown in many external funding for health program in Africa, for example, the UZ. Do you think this could contribute to worsen the problem of accessibility and availability of levodopa in Africa?
I mean, my understanding is that the infrastructure of the WHO, some of the, other infrastructures that are there are dependent on some of this funding, in just, creating infrastructure, creating, bigger networks, if we can borrow things from HIV care or other care. So I do think that it's going to impact things. When there's limited funds, people tend to shuttle them into things that are imminently, a cause of death. So perhaps things like malaria may be focused on instead of, Parkinson's at the moment. You would have to tell me kind of how it's impacting you so far. But I think this is even more of a reason why we at the MDS need to think about ways to strategize, and the countries that are still able to do work in Africa, like in Europe, or Canada or India or whatever, can, rally together to sort of work together, to help each other, because I think the work needs to continue. And, you had described to me that there are patients that have a supply and then the supply ends. And, the last thing we want is to have, the supply chain cut off completely because of some external situation that's not in our control. So I think we have to fight together to continue to, push. And I think the IGAP timeframe, there's a number of other things that I think are highlighted right now. A WHO paper that came out as well, highlighting a number of low-hanging fruit that they think can be tackled in Parkinson's. So I think that we need to really push. But I probably, I think we would be naive to think that the lack of USAID funding would not impact this in some way. But maybe you can tell me.
Yeah, of course, this will impact the health priority. We know that in Africa, we still have the double burden of infectious communicable disease and non-communicable disease, which are on the rise. So even though the funding were most focused on infectious disease and maternal and in neonatal health care, um, this will change a lot in terms of resources available for other health programs. However, this also give us the opportunity to look for to challenge ourselves and to look for other funding, especially internal resources. Africa is one of the richest country in terms of resources, but the poorest in terms of healthcare provider. So we have to think of improving our local workforces, improving our local funding sources so that we can be more resilient regarding the shutdown of external funding. Even though we still have to work together hand by hand with our partners and this in the for the benefit of our patients.
100%. Thank you so much, Daniel. Is there anything else you wanted to say and close? Because I think, we had talked about the fact that in Cameroon, you have the medication is registered. You can prescribe it to many people, and some of your patients are able to afford it. But the lived experience of you as a doctor is very frustrating because despite all of those things, which is actually a lot better than many countries in Africa, you still have a lot of barriers to getting this basic drug into the mouths of your patients. Do you want to comment on that?
Yeah, yeah. In Cameroon, like I think it's the reality of many other African countries. Even though we have access to the medication, there is a huge disparity because the medication are available in the main city, the major city, especially the two main capitals, economic and political capital. But when you go into regions and rural area, the medication levodopa is not available at all. So regarding this patient who live in this area, especially rural area, generally they don't have access to the medication. And those living in urban area, even in the capitals, they the medication is available intermittently, so they may have uh, enough money to afford for the medication, but at some point they can go to the pharmacy and the medication is not available. And those who don't have enough funding, and this is the reality of most of my patients, they get the medication when it is possible for them. So with such intermittent accessibility to medication, generally we don't expect the patient to improve as we want, and it is a very disappointing for the physician we are, because the patient will come with the same complaint in our consultation, and we don't have the enough mean to fight uh, for more availability of levodopa in our context.
Yes, we have to change that. Thank you so much for the work that you do, Daniel, and thanks for taking the time to highlight this paper. I'm glad that we could come to sense that this is important and that we have to partner together. And anything that I can continue to help lift your voices, please do let me know. So thanks everyone for joining.
Thank, thank you, Prof. It was my pleasure.